Hey guys, this is the fourth quarter EMS action items here with Dr. Roach, and hopefully you get some good information out of the following.
Looking at our on-scene times, trauma and stroke, the goal there is 10 minutes, so we have a little bit of opportunity to make some improvements there. As far as the 12-lead EKG, phenomenal, so we're at 6 minutes. So just consider these trauma patients and stroke patients. Again, these are alerts, and the idea of an alert is to get off scene, get them to the hospital as soon as possible. The rescue pod, our goal is 100%. This is a device that definitely improves the neurologically intact survival by increasing blood flow to the brain. It's called an impedance threshold device, is what ITD stands for. Make sure that you document that not just in the chart, but the flow chart as well. And then end-tidal CO2 is 95%, so we're only about 5% off our goal of 100%. This slide reviewing SOGE 132 and SOGE 128. Everyone, this is just a reminder about shift report review and timely completion of the reports. We need these charts to be locked by the end of the shift. Thank you.
We've been doing a great job in the last quarter, specifically with whole blood. The officers that are in the field have really understood what to look for when it comes to a whole blood opportunity. Getting EMS 17 on these calls, or air rescue, or whatever case, air rescue or EMS 17 on these calls as early as possible, especially when they weren't put on the call. We've had a lot of really good outcomes last month and actually the whole last quarter. But Dr. Roach and I want to talk to you about what to look for specifically with females, specifically pregnancy-bearing age females.
I have to tell you, I want to say that it's amazing what has been accomplished just this last year with whole blood. I have to congratulate the quality department, Chief Clark, all the air rescue personnel, EMS 17, and all the other members of the team that have made this happen. We have now moved this thing to the point now where Memorial is now giving whole blood in their trauma centers. Broward Health is looking to get this done. Kendall Regional does this without the influence of us. They did it on their own, and it's just wonderful to see, and we're making a huge difference. Recently, well, in the last year, I think one of the things that changed was we lowered the threshold to give paramedic discretion, which actually led to increased usage of the whole blood, and you've saved a lot of lives because of it. Now, the one thing that I just want to put on the radar and just keep you aware of is, as Lieutenant Kravanek said, the women that are in the age of pregnancy, potential pregnancy, we have to be careful of the potential for an RH sensitization. And we don't know what their RH factor is, so if they happen to be RH negative and we give them whole blood, we're giving them O positive blood, so we could sensitize them, which could affect subsequent pregnancies. It's not going to affect them at this time, but down the road they'll have a difficulty getting pregnant and maintaining a pregnancy. So the request from me is just that when you have a patient, a female, that is in this age, that we do very tight control with respect to criteria. So in these cases, we really want to make sure the patient's having, trauma with hemorrhagic shock as per our protocols. Just be aware of it, and then just be sensitive to the fact that and I don't want you to hold back the blood. That's not the intention. If the young woman needs blood, I want you to save her life. I just want to do it in the times when you feel it's necessary, and just you have that caveat that we could cause harm, and we have to be sensitive to that fact. So if you give it because they meet criteria, and then when they get to the hospital, we try to get information so we can, once we get the blood typing, we can see if the woman is RH positive, we're out of the woods, we're fine.
Right.
If she's RH negative, then we have to follow this, and I'm considering some other things with this hospitals to do ROGAM therapies and different things like that, but that's a whole nother topic. But these are things that I think we just need to be cognizant of and work through this together.
So one of the things that we were talking about potentially was, if you have a female that would meet typically a paramedic discretionary blood transfusion, that maybe the safe play, let's just say her blood pressure is 90 and her heart rate's 110, right on the cusp, and we would normally use paramedic discretion to give that. But if she is a female, we were talking about giving fresh frozen plasma first to see if she has a positive reaction, blood pressure stabilizes, heart rate lowers, end tidal comes down, and everything normalizes before we go right to the whole blood. Would you agree that that's probably a better play,
Yeah,
safer move?
I think that's a good move, especially when if it's in the gray area. I don't want you to think that if this young woman is in hemorrhagic shock, I don't want you to hold back the blood. But if it's in the gray area, then yeah, definitely we could still give her plasma that has the AB, and that could be off and cause just like anything. But I think that's a reasonable to give plasma, maybe fluids, and see how she does, and then go from there. But definitely, I just want to say one more time, if the patient's in hemorrhagic shock and there's concern, please give the whole blood. It is what it is.
We talked about this last time, specifically in cardiac arrest, and about how important the puck placement is, to use the puck, not only that, but to also where to place the actual defibrillation pads during a cardiac arrest. Unfortunately, EMS 17 and I have gone to a few calls recently, and we're not seeing much of a change. The people are still using the anterior lateral placement for the pads. I just wanted to clarify with them how important it is to do this, especially with this dual sequential defibrillation, and why we want them to do this.
Yeah, absolutely. So when you think about the anterior posterior placement, it's in terms of improving outcomes for the patient. That is the vector that's going to give you the best chance for a good defibrillation. So starting there is the best thing for the patient. But now the other thing that we always try to do, and my two things I'm always looking to accomplish, is how do I make your jobs easier, and also at the same time improve outcomes for the community.
Right.
So anterior posterior improves the outcomes for the community. The next thing is, the reason why we have pit crew and we designed it and we practiced it and we drilled it was because we know if we're going to do double sequential defibrillation and you already have the patient on anterior posterior, it's easier to place anterior lateral, especially if they're already on the auto pulse. So now, if you guys don't follow the pit crew, which is designed to make your jobs easier, you're making your jobs more difficult. Because now, if you have a patient's refractory V-fib and you've shocked them 3 times and now you want to go on to double sequential, you are now going to have to go through a lot of work to get the second set of pads in. And in many cases, as we've seen, they don't end up doing the double sequential, probably for that reason.
Right.
So let's do this, guys. Let's follow the protocols. Let's look at the stuff. Let's acknowledge the fact that time has been spent trying to make your jobs easier and improve outcomes for our community.
Absolutely agree. I'm going to take a minute to talk about Narcan. We're seeing a lot of uses of Narcan specifically, and we all know that there are a lot of patients that need Narcan, but we need to talk about the protocol specifically. Narcan should only be given in patients that have a respiratory depression of less than 10 a minute. We're only using that as a medication to reverse respiratory failure. We're not using Narcan just because they took heroin and they're unconscious and they have a respiration of the 12, we want them to wake up. That's not the case. We don't want to do that. And Dr. Roach, could you elaborate on that a little bit?
Absolutely. So, as you stated, the Narcan reverses the opiate, but what we're looking for, the reason why in many cases they're altered is not just the fact that they're opiate overdose, it's because their CO2 levels are high because they have respiratory depression. So the first and best thing you could do for the patient is bag valve mask ventilate and remove that CO2. They're going to start waking up. And so in many cases, you probably don't even need the Narcan. But but obviously it's there for a reason. If you're going to bag them, you give the smaller the dose of Narcan, the better, and slowly bring them out of that opiate withdrawal. You don't want to give them. That's why we don't give large doses of Narcan and totally remove the opiate. Because these people are usually chronic opiate addicts, and if you take away all of the opiate response, then you could cause severe reactions. You could cause the vomiting, the diarrhea. There's this flash pulmonary edema. So all of this is stuff created by overdosing and slamming them with large doses of Narcan.
Right, which we've all experienced, that the vomiting and the diarrhea, I'm sure, and that's just something we don't want them to go through. If we can just support their respirations, they'll blow it off, and if they don't, then we give them a little bit of Narcan and help them. But while we're on the subject of Narcan, can we talk about it in cardiac arrest as well? Because it seems to be one of the things that people will say to me. I'll say, hey, why did you guys give Narcan on this? Not that I'm mad at them for doing it. I'm just curious what their thought was. And they're like, well, we don't know what kind of medications they're on. Maybe they're 85 years old and they're taking Percocets, 100 Percocets, and that's why they're in cardiac arrest.
Yeah. Yeah, so the Narcan, again, same scenario. By the time they get to cardiac arrest, they need to go to the protocols that we use in our PIC crew and, chest compressions and proper ventilation and get their get them to ROSC. Once we have ROSC, then going down the line and thinking about reversing opiate, but they're not in cardiac arrest because of the opiate. The opiate caused them to go into respiratory failure, hypoxia, and then there was a downward spiral. So the opiate, although it probably doesn't hurt in a cardiac arrest resuscitation, you're really offering no benefit. It's just, I want you to focus on the things that save lives, and the things that save lives are their PICU CPR, staying on scene, running our objectives, which we've talked about before, and that's what I really would like you to focus on.
We talked earlier about going to these cardiac arrests and seeing how people are working them, anterior, not putting the pads on, anterior, posterior, etc. One of the things we're also seeing is that we'll have sometimes I'll be reviewing a report and I'll see that people have had like an 8 or 9 minute on scene time, or we'll even get there and by the time we'll get there they're in the back of the truck working them, and have had conversations with different crew members who are like, well, we're going to move them into the truck and then we're going to stay on scene for 15 minutes. Listen, I just want to make it clear, staying on scene for 15 minutes in the back of the truck is not something we should be doing either. The idea behind this protocol was to stay on scene and work these patients for at least 20 minutes to give them the best chance of survival possible. We want to get to a point where we start following the protocol with death in the field protocol. If you work a patient for 20 minutes and they're asystolic and you've gone through everything that we've, the epinephrine infusion and all the medications, and they're asystole, we should be getting more comfortable with calling them as a signal 7 in the field and not taking a dead person essentially across the county, code 3, lights and sirens, to the hospital where they're just going to call them. And I know that's something that's hard to get behind. I want people to try to understand why we're doing this, with the intention behind the 20 minute on scene. It's not 20 minutes on scene in the back of the truck. It's 20 minutes on scene so that we can work the protocol and potentially the death in the field.
Yeah, it's a whole paradigm shift. I mean, I know that from years back, the idea was, hey, get these patients in the back of their ambulance, take them to the hospital, and offload this to the hospital. But we know that in the cases of when we talk about our alerts, the hospital has something that we don't have. So SEMI alerts, stroke alerts, there's specific trauma alerts. These are all specific things the hospital has we don't have. In cardiac arrest, it's not an alert. Cardiac arrest is something that we have everything the hospital has. There's no rush to get to the hospital. So what we need to do is offer them the best chance. Now go back to the 2 criteria. How do I make your jobs easier and improve outcomes for the community? Well, staying on scene is meant to make your jobs easier. Whenever you have critical actions that need to be accomplished. Chest compressions need to be started, and you can't interrupt chest compressions. You need to do proper airway management with the IGL and the correct ratio, correct bagging sequence. You have to drill the IO, start your epi drip. All these things are critical actions, and when you mix into that the other action of let's package them up and get them to the back of the ambulance, you're interrupting the things that are the most important. So if you want to save this patient's life, do the things that are the most important, which is what I just stated. Stay on scene, get on the ground, do the things, and make every effort to do it the right way. When your life is in danger or there's a situation, we understand that you have to do whatever you have to do to protect yourself and your team. But do that as a last resort. That's going to make your jobs better. It's going to make the patient's outcome higher probability for success. And then, as Lieutenant Kravanik said, once we get comfortable with this concept and the paradigm is shifted, then we can make things even better. Because now, instead of going code 3, risking the rest of the civilians when you're going code 3 to the hospital and potentially causing accidents, you don't need to do all that. You can stay on scene, and then we would actually be comfortable terminating on scene and not transporting patients to the hospital.
I get a lot of questions about, like, what are we looking for as far as a sepsis alert, and does ESO even match our sepsis criteria? When there's a screenshot on the page that you're looking at right now, and this is actually in the sepsis screening section. So what you're seeing is the prerequisites and the QSOFA format, which is what our protocol actually follows. Below that, there's another one called SIRS. We do not use SIRS in the field. These 2 criteria is what we use, and mainly it's the QSOFA to determine whether or not they're in septic shock. The big thing that we got to do, no matter what, in these patients is first put them on end tidal, because the questioning right away is that it's not really as important about the tachypnea. It's about having an end tidal of less than 25. Having an end tidal of less than 25 and a systolic of under 100, right away you're already meeting criteria. And this will help you diagnose that. But we got to see people putting end tidal on sepsis and giving the 1,000 ml fluid challenge regardless of blood pressure.
The only thing I could add to that is Reason why we don't use this, so the science behind SIRS. If you do a SIR, if everybody has SIRS positive, you take to the hospital as a sepsis alert, then you're going to over triage, and it's going to dumb down their response. They're going to go, look, everybody's SIRS positive.
Right.
But if we use QSOFA, that's the severe sepsis and septic shock. These are the legitimate, real deal. These people need to be acted on, very aggressively at the hospital. So this will make this a more important message to to the hospital. When EMS calls, or when they hear BSO is calling sepsis alert, they know this patient's coming in and they're going to be sick and we need to get to the bedside. Similarly to a STEMI alert. It's not like every chest pain gets a STEMI alert.
Right.
It's the ones that are the most critical, and we can go on and on. But that's the general.
Well said.
Yeah.
I appreciate everyone's attention. If you have any suggestions of what you would like to see or anything, please reach out to myself, Chief Clark, or Dr. Roach, and we would be happy to include that.
Thank you all. Thanks everybody in the quality department and all of the members of the BSO service, because the 2020 and 2021 were brutal years for everybody, and you guys crushed it, and you supported the community and each other, and my hat's off to you, all of you.